Hi, everyone. Thank you for joining us today. We're very excited that you're able to be with us today to kick us off through the month of April. The SDOH Academy, we were intentional about presenting this breakthrough series during the month of April. It is Minority Health Month, and we felt it was really appropriate to launch our series this month. So this is the breakthrough webinar series, and this particular webinar is actually facilitated by a team of us. So before we get started, I want to acknowledge HRSA and their support of this efforts. And then, so these are the presenters or the faculty for today's session. We've got our colleagues, Albert and Sakura from AAPCHO. We've got Jamie and Colleen from the Center for Supportive Housing. We've got myself, Eureka de la Cruz, and Nalani Tarrant from National Association of Community Health Centers. And then Gladys Garillo from the National Center for Farmworker Health. And then we have a very, very special guest. We've got Nasha Chaudhry. She is from My Care Health Center in Michigan. And so you'll be hearing from her later on. So just a couple housekeeping items. Today's session will be recorded and we'll be sure to send out the slides afterwards and any resources. Please use Zoom. I'm sure we've all been in this for a year now, so please use chat. We would love to see any reactions, so please be sure to use the reactions if you like, as well as the Q&A section. And if you need to say something, raise your hand. And then also we want to just acknowledge current realities. There's a lot of things happening in the background, so if anything happens, we'll be sure to try to jump in and help out if anything's needed. So again, this is the Breakthrough Series for 2021. And the reason we named it the Breakthrough Series is we know that there's a lot of information out there. We wanted to allow you guys a chance to break through all the clutter and find the resources, experts, and any sort of peers that are available to you all in terms of knowing more about SDOH. So for today's session, we're going to, the formal agenda is for an hour, and then you'll have the option to stay with us for another 30 minutes for an office hour. So if you have any additional questions or you want more details, please hang around with us. We'll be sure to answer any questions. Being that this is a webinar series, there are 3 other sessions after this, so please be sure to register for them. They'll all take place on Thursdays at 3 p.m. So same time, same place, the same day of the week. And then all the recordings will be on the SDOH Academy website. So with that, we'll go ahead and jump in. So this is our first learning objective. We hope that you will have this opportunity to really understand how important it is to track social determinants of health data as well as enabling services data. So when we think about the competency, this is the first core competency through the SDOH Academy. You see here that, we want to be able to have information around enabling services for SDOH. So we want to provide opportunities to document them and really track what are the resources that are needed for underserved populations. And then the second part of this competency is really looking at the technology aspect. What is the infrastructure that's needed so that we can address and assess SDOH needs? But more importantly, we want to be able to track all of this important information so that we're able to improve health access, provide quality care, and then really allow for patient engagement. So before you are able to actually address or document social needs, you really need to document them, right? So if we're addressing social risks, it's really important to document them. We have to have both in serving the needs of our community. So this graph right here, it looks at the different use cases for collecting SDOH data, as well as interventions and how this plays out from the patient level all the way to the policy level. So we see that this information at each of these different levels is very powerful. Obviously, we want to provide the best care for our patients and their families and their caregivers. And having this information allows us at health centers to really think strategically in terms of how do we develop our care teams, what are the knowledge or the skills needed to provide those the level of service and care for our patients and their caregivers, But then also still within the health center, how do we establish and look at external partnerships that will allow us to provide any sort of resources or referrals to our patients? Well, we don't want to just stop there. Advancing health equity in our communities is more than just a referral. That is just one small step in really advancing health equity. So this is when we think about how can we use our data to really advance health equity policies. So advocacy efforts are really important here. We also are able to take a look at the community in terms of what's happening. How do we share data? How do we coordinate our efforts so that we provide a nice seamless continuum of care for our patients? Obviously, we want to be able to have closed referral loops with our external providers, but really it's more than just closed referral loops. We want to really be able to have the opportunity to identify what are the pain points in our policies, in our structures, in our systems that are causing these health outcomes. It's not by accident. We see those health outcomes very intentionally. So how do we start looking at those policies and systems and changing them? And then finally, more advanced, having this data allows us to really demonstrate the value of health centers, but more so the need for these services in our communities so that we're able to have some sort of financing mechanisms behind it so that we're able to sustain this level of work. And then obviously, hopefully we're able to then inform state and national policies so that we really get a more structured system in terms of advancing health equity. So these are some very, very high level patient perspectives. I worked at a FQHC a couple of years ago. So James was a patient of ours. He didn't have transportation. He would always get kicked out of different health systems. He came to our health center because he was finally kicked out of the two major health systems and realized that when our community health worker and our social worker went to his house, the reason he was missing his appointments was because his doorbell was broken. Imagine that. So this was something that our community health worker and social worker were able to identify. The next patient is Ashanti. She has limited English proficiency. She's trying to fill out all these applications, but they're all in English and she speaks another language. So she worked with our community health worker to figure out how to fill out these applications. In our community, we were able to realize that we had a rising need for different languages. We had some applications in Spanish, but we realized that we needed more languages in our community given the increase in refugees in our community. The third example is Maritza. She's a single parent. She needed food. She's a single parent with 3 kids. She needed food for her tuberculosis treatment. We didn't realize that she was giving the food to her kids and not eating it herself. So she actually ended up passing away because she wasn't taking the medication and she was giving the food to her kids. And then finally, we have Kai, who depends on a caregiver. The caregiver is a family member. There's a lot of honor and grace for Kai to make sure that he is healthy as possible. But Kai, doesn't understand that his caregiver doesn't truly understand how to manage the medications. So that's leading to a lot of, hiccups in his treatment plan. And so this was a situation where we really had to intervene with the caregivers so that the caregivers understood what it was that Kai needed in their treatment of care. So these are just all examples of needs that our patients had at this health center. I'm happy to report they're now using PRAPARE, but before we weren't using PRAPARE. And so if we had gathered these needs beforehand, we would have been able to really address them in a more holistic manner. So again, earlier I talked about having, when we think about social determinants of health data, there's 2 things that go hand in hand. The first is the needs data. Having a standardized data set on patients' social risk and barriers is really important because it allows us to assess in a uniform way that we're asking the same questions, not necessarily the same questions word for word, but we're asking the same elements. We're going through and screening the same elements together. And on the other side of that coin is the response data. What sort of interventions are we doing at the health centers to respond to the needs that we identify at the health centers? So again, there's a correlation between both. And both are necessary. You can't have one without the other. Really, it's so powerful to have both sets of information so that we're able to demonstrate health center value to payers, really seek adequate financing. It takes money, effort, and people to do a lot of these efforts. So we really need to make sure that we have a sustainable funding model. Beautifully enough, this information allows us to really target and improve our services. It allows us to be very specific and very targeted with our efforts. I've heard a colleague before say, let's not take out the machete, let's take out the scalpel. It might not be the best example, but it really allows us to be as precise as possible. And then finally, at the end of the day, we want to make sure that we have a system that's integrated, that's value-driven, and that we're able to really reform the system so that we can reduce the total cost of care. So with that, I'll hand things over to Colleen.
Thanks, Yuriko. So I'm just going to pick up a little bit on some things you most likely are familiar with at this point, being health centers and understanding UDS reporting. And also do some polling with you guys on some questions that are already a part of UDS and HIT data, and see where your responses lie at this point. So this should look familiar to everybody, right? HIT data, or the Health Information Technology Form, includes a series of questions, right? EHR implementations, certification of systems, and how widely that system is adopted throughout, right? Everybody is contributing into UDS. We have seen some changes over the years. And to our benefit and to our discussion today, some of those changes are directly related to SDOH. And are you using screening? Are you doing SDOH screening? And what are you finding about your patient population to date? Next slide. So as this might look familiar, so one of the questions right now in the HIT questions is, does your health center collect data on individual patients' social risks, right? We've been trying to understand throughout all the health center across the country if people are, if they're not, and or if they're not, are you planning on, are you working towards starting to screen for social determinants of health? Next slide. So what we would like to know from everybody today is exactly that answer. So we're going to launch a poll, and if you could just take a couple seconds to answer where you are on that question to date. So do you screen, you don't, but we're in the planning stages, or are you a health center right at this point that is not planning to collect this information at this time?
Colleen, I'll give everyone about 5 or 10 more seconds, and then I'll share the results.
That would be great. I can't tell. I didn't know if this was like real time. I was just going to ask them, like, are people hitting things? Because I can't see anything. If people
No worries.
Or not.
I'll share in just a second.
Thank you, Emily. All right. Oh, great. Okay, so about almost 70%, which I think we've seen nationally. No, but you're in the planning, and we have about 10% right now on the call that aren't planning to collect this information at this time. So thank you for that. That's very helpful. But that has been, looking at UDS data since it's been collected, that's been kind of the national average. So I guess you guys are panning out as the national average on this call today. Next slide. So somebody had already put a question in about what's PRAPARE, but another question is, if you are screening or you're looking at screening, what kind of standardized screeners for social risks are you using? And here are some of the most used right now, or most known. PRAPARE is one of them, but there's the Accountable Health Community Screening Tool, and a bunch of others. So there are some that are out there. There are some that are looking at all aspects, at some aspects, things like that. So we would also like to know from you guys in poll number 2, of those who said you are screening, what tool are you using currently? And again, we'll give you a couple seconds to fill that out. And if people have questions about different ones or want to talk more screening depth, we do encourage you guys to stay on for office hours at the end of this.
I'll give everyone 5 or 10 more seconds, and then I'll share it again.
Okay. And we do have a big group at this point who is doing it. That is using PRAPARE. That's great. All right. Thank you. Thank you for participating. Next slide. So what has been recently become a part of the questions is they are starting to ask very specific SDOH areas, which is when you are doing screening, can you now please provide your patient populations or the number of your patient population that has food insecurity, housing insecurity, financial strain, or lack of transportation or access to public transportation. We know that there's more social determinants of health out there, but we have seen nationally, and this, you know, again with health outcomes, that nationally these are the largest ones and are the largest ones that have impact on people's health outcomes. So at this point, they are starting to ask these four particular to start gaining information around of the patient population out there with social determinants of health. What are the numbers and what are, you know, what is it looking like in the community around food insecurity, housing, financial strain, and lack of transportation. Next slide. And then one of the last ones is if you do not use, you know, standardized assessment, you know, why? Why is that, right? So this is also getting to the point of, you know, for us as part of this breakthrough series and part of, you know, talking about SDOH overall, what are the challenges? Like, what is the difficulties for health centers at this point to do screening, to be able to have it be a part of your workflow on a daily basis? So also trying to glean some information around that. So this is something that we would also, if you could just take a couple of minutes, would really love to get some information as well from you on the call today. If you are not doing it, you don't have these assessments, it's not in the workflow, what are the reasons behind that at this point? And again, we'll give a couple of seconds. Yes, thank you, Emily. And if you do select other, if there are some other reasons or there's some challenges that you have found in trying to attempt this, we would love to see that in the chat. Lack of training for staff, okay. Well, thank you so much. This is really helpful to us and part of this discussion, but also in moving this kind of work forward with all the health centers. So at this point, I'm going to hand it over, I think, to Gladys.
Thank you, Colleen. And several of you have already entered in the chat some questions about the actual screening tools, and we're going to go over some of them now because a part of the process in identifying social determinants of health is really figuring out how to do that and ways that you can gather patient information and then figure out a plan to address such barriers. Next slide. As most of you reported in the poll, PRAPARE is one of the more common tools utilized by health centers. And this tool is in the National Clearinghouse. It is a set of, it consists of questions that measure the national core measures for community priorities. This tool was really developed and informed by research, so it's evidence-based. And it aligns with national initiatives prioritizing social determinants of health, like Healthy People 2020. So PRAPARE truly does emphasize measures that are actionable through implementation and the action toolkit that is available. And it also offers a readiness assessment for you to determine, you know, if your organization is ready. So for that small percent, about 10 that indicated that you are considering or wanting to implement some sort of screening tool, this could be a good way to assess whether or not your health center is ready for implementing items such as PRAPARE. One of the most great things about PRAPARE is that it really is available in 26 languages, And not only that, it also offers electronic health record templates in certain software, so you're able to integrate it into your EHR system. So it's a great tool, and one of our colleagues from AAPCHO was involved in the preparation of it, along with NACC and OPCA. Next slide. Now, here are some specific screening tools that the National Center for Farmworker Health has available. One is a self-assessment tool for health centers, and it allows health centers to evaluate how they're screening and addressing SDOH within their patient population. Oh, there we go. And the patient assessment tool is really to be filled out by the patients, so that health center staff can really evaluate their needs and then develop a plan with them to identify resources that they can refer the patient to. We do have 2 new tools that were recently developed out of our SDOH IAC Plus Learning Collaborative this past year. That was led by Alexis LeBoy, one of our facilitators. And it's the SDOH checklist and a customizable screening tool. We are wrapping up that learning collaborative now, but are currently recruiting for additional health centers for our next year's work plan. And we will be providing support. So if you're looking to customize a tool for your health center, we encourage you to reach out to us so that you can participate in the learning collaborative and receive that one-on-one support. Alexis is also currently working on an SDOH hub, which is a web page that we're developing at NCFH to be able to house a number of these screening tools and outcomes from our learning collaborative. So I encourage you to please connect with us, sign up for our monthly newsletter so that you have that information and know when the hub is active. Next slide. A few other resources that NCFH has are related to language access services and implementation of such programs. And you can see them here. A language competency checklist, an assessment and planning tool, again, for the health center to determine whether or not they have the structure and workforce available to implement such a program. And then a step-by-step process for how to go about implementing a language access program at your site. We also feature a webinar series that we conducted with the Farmworker Health Network in 2019. So as you heard Colleen mention, the 3 top kind of priority SDOH factors that are commonly seen amongst our patient population are transportation, housing, and food security. And so the 2019 webinar series addressed those 3 specific areas. So I would encourage you to check it out. The recordings and gather more information if that's something that you're wanting to learn more about. And now, as we know, with COVID-19 being a new social risk factor that truly has exacerbated current barriers and challenges to healthcare, we have a specific COVID-19 webpage that is full of resources that can provide support and information for how to address the impact of this national pandemic. Next slide. Some of the other screening tools that you guys probably noted in the question that we presented with the poll are included here. The Center for Medicare and Medicaid Services Health Community Screening Tool is a tool that helps healthcare providers find patient needs in 5 core domains: housing and stability, food and security, transportation, utility assistance, and interpersonal safety. So all great questions meant to be answered by patients themselves and or a parent or caregiver of a patient to be able to gather information about their needs. The Health Begins screening tool and guide that actually assesses for social needs in a few other domains that include education, employment, social support, immigration, housing insecurity, food, transportation, violence exposure, stress, and civic engagement. Now, the iHealth Social History Questionnaire is a little bit more condensed. It's 14 to 24 questions, and it only assesses 5 main domains, which are pretty similar: economic stability, education, social and community context, neighborhood and physical environment, as well as food. And this is actually a pretty neat pocket card that you can check out that was reproduced by the American Academy of Pediatrics with the permission of the National Center for Medical Legal Partnerships. Now, the We Care survey was designed to also meet or identify unmet social needs within the patient population. And it also is utilized as a family-centered approach to determine what type of assistance the patient needs. So that is available online by the Boston Medical Center. Health Leads is a social screening toolkit, and it also addresses 7 social domains, and they're pretty similar, so I won't list them again, but food security, housing, etc. That again, look at the patient needs and then help the health center staff develop a plan in order to address those barriers. The WellRx questionnaire is a patient-reported screening tool that was institutionalized within the University of New Mexico Health System and the First Choice Federally Qualified Health Center. And it also assesses all, over several social domains related to health and how helps you determine what types of support systems the patient needs. Next slide. The Everyone Project by the American Academy of Family Physicians is offers another great type of resource because it has the full package available. It's the guide, the screening tool, and then actually provides this neighborhood navigator that allows you to identify specific community resources to address the needs reported by the patient. It also includes an action plan, which is a quick form guide that you can discuss and use with your patient when you're talking about social determinants of health. And then it allows you to develop a plan with them so that they have it and can take it with them. And this is actually available, this tool, the action plan, and is available in 7 different languages. So it's also something that can be customizable to the needs of your patient. Next slide. So all of these tools that I just listed are just, a number of tools that you can utilize and incorporate within your health center. But after you start to screen and identify needs, then what? You have all this data and you're not really sure what to do with it. Here are some support resources that can give you information and assistance on how to evaluate that information that you've gathered and then really put it into place to implement within your service delivery. So if you're gathering information about a particular social determinant of health, how does that impact your enabling services, right? And so we have some resources here listed that you can utilize to help you sort through the information and figure out how to implement it into your service delivery. We have AAPCHO's Enabling Services Accountability Project, and this was developed to increase EMP data collection and to evaluate the impact of enabling services on healthcare access and health outcomes. NACHC also has some information and support about enabling services on their website. The PCA has a podcast series that is available that has great information about enabling services too. So we would encourage you to check that out. And then the Corporation for Supportive Housing has best practices available for health centers that really target individuals that are unhoused and that offer homeless services. So as you can see, there's just a number of different resources and tools available to you that can assist in the screening, documenting, and addressing of social determinants of health within your patient population. So if you have any particular questions, as Colleen mentioned, we encourage you to stick around to office hours to address those or to check out any of the resources that we have hyperlinked within this presentation. I will now pass it along to Albert, who's going to be presenting our guest speaker.
Thanks so much, Gladys. So we're going to segue to our health center guest speaker and highlight here. I'm excited to introduce you all to NACHC Chaudhary, who is the Director of Operations for MyCare Health Center, again, based out of Michigan. And prior to NACHC's role at MyCare, she served as the Associate Director of Operations and Enabling Services at the Michigan Primary Care Association. So NACHC definitely brings a great perspective at the state and local level. NACHC completed her Master's of Public Health in the Department of Health Behavior and Health Education at the University of Michigan School of Public Health, and also completed her Bachelor's of Science degree in the Department of Health Sciences at Oakland University. NACHC's interest in the field of public health stems from working with populations facing racial and ethnic disparities that often lead to low health inequities in various communities due to the impact of the social determinants of health. NACHC seeks to continue efforts on breaking down these barriers to access to care and by addressing the social determinants of health needs in the patient population served at MyCare. So it gives me great pleasure to pass the mic over to NACHC, who again will share some best practices. Take it away, NACHC.
Thank you, Albert. Good afternoon, everyone. This is exciting. It's been a while since I've presented, so I appreciate the opportunity to do so. So as Albert mentioned, I used to work at the Michigan PCA, and I've transitioned over to working at a health center actually right before COVID started. So it's been an interesting transition, and I've learned a lot, and I'm sure a lot of you have as well. So I'm excited to talk about social determinants of health with you. This is a topic that's near and dear to my heart, and I've actually went into public health to address a lot of these issues. And so exciting for me to be able to work in the front lines and be able to provide that support to the populations we serve. So just a brief overview of some of the things I will be talking about. I'm going to go ahead and just provide you with a quick overview of MyCare Health Center so you understand a little bit of the demographics of the patients that we work with. And then I will transition over to just briefly talking about the SDOH model and what we look to do in addressing social determinants of health in the work that we do. And then I will transition over to sharing a bit about how we collect SDOH data here at MyCare, and then how we utilize that data to help us make decisions and find the best way to serve the patients that we do. So with that, I will transition over to the next slide. So I did want to provide a quick timeline of MyCare Health Center. So we're, not that old in terms of how long we've been operating as a health center. We opened up in 2010, and then we actually transitioned over to a new access point in 2014. And I apologize, so you're going to have to click through a couple of these, so feel free to go ahead and pull up the text there. So we transitioned to the new access point in 2014. And then we added our dental services in 2015. And then we actually were a pilot program for the Connection to Care program, which actually was able to serve citizens who are re-entering into the population after serving some time in correctional facilities. And then we actually added direct dental services in 2018. So prior to that, we were providing dental services through contract work that we did with a different organization, and then we decided to bring dental in-house. 2016, I do want to mention, so we added the medication assisted program, and so a lot of our behavioral work was specifically through that program, and then we expanded some of our enabling services work. And then in 2020, so right before COVID hit, actually, MyCare decided to expand their integrated health program. And so we brought on a new director of integrated health. And so that program has been growing over the last few months while we've continued to make sure that we're providing the primary care services that we already have been doing, and then doing some of the work around addressing COVID within the population as well. So on the next slide, I've provided just a quick snapshot of what our patient population looks like. And so you'll see some of the UDS data for 2019. So we're a relatively small health center organization. We have 3 clinic sites. So one of our sites is actually currently closed due to COVID, and all 3 of our sites are actually co-located with different community partner organizations that we work very closely with. So one of those is actually co-located with Easter Seals. They do a lot of behavioral health services. So we have a lot of shared patients here at Centerline. In Mount Clemens, we are co-located with some of the county organizations, and so we work very closely with them across actually all of our sites. And then the Clinton Township one is co-located with the Macomb County Community Mental Health Organization. And so as you can see for the patient visits, we're just under 15,000 patient visits per year, and you can see the breakdown of that. I won't necessarily read too much about that, but I did want to just point out a few things in terms of demographic. So if you look at the different range of patients that we serve in terms of the age, the race, and then even a breakdown of male versus female, I wanted to include that information for you all to just take a look at. So in the next slide, I briefly provided a quick blurb / informational slide that kind of talks through what the social determinants of health model is. And I'm sure a lot of you folks are doing this work and so are very familiar with what are the needs that we're trying to address when we're looking at serving our patients. You know, when we're talking about these patients who are struggling with different barriers, whether that's access to care, whether that's folks who are struggling to, you know, get the education that they need, the job that they're looking to get, whether that's a training issue, whether that's a barrier due to transportation, due to having that support within their communities, being able to access various things that actually ultimately, as we all know, impact their health and well-being. And so understanding that the model of taking care of those social determinants of health is so important for us when we're having these conversations with our patients, whether that's about, you know, hypertension, or we're having a conversation about diabetes, or we're having a conversation about obesity. You know, we as people have so many things that really impact how we take care of ourselves. And physical health, as we all know, is only a small component of it. So knowing a lot of these things and having these conversations with our patients is so vital to be able to support them in making healthy changes and addressing their health and wellness long term. So with that, I do want to transition over to data collection. And so I feel like I'm a little bit of an outlier because I know when I was working at the PCA and working with some of the colleagues on this webinar, we've had lots of conversations about PRAPARE, and I pushed it with a lot of the health centers throughout the state. And so it's really been interesting to be here at MyCare because we've had conversations with Allscripts on several occasions about being able to utilize the PRAPARE toolkit within Allscripts. So if there's other folks on the call who utilize Allscripts, you all know that PRAPARE is not necessarily already embedded into the Allscripts module. So one of the things that the staff here were able to do was utilize that SDOH questionnaire that's available in Allscripts, and we tweaked it a little bit to make sure that it aligns and addresses a lot of the questions that we know are incorporated into PRAPARE. Because for us, you know, at the end of the day, PRAPARE is a great tool. We know there's other questionnaires that are available for us to be able to pull that data, but we just want to make sure that we're asking all the important questions to be able to address any concerns that our patients have. And so we were able to embed the SDOH questionnaire and some of the issues that we've recently run into. And I know the staff have been continuing to have conversations with the ZARA, with several different organizations to try to figure out what's the best way for us to address is that, and I'll talk more about Azara later on. So Azara is the integrated data system that is able to extract the information that we put into Allscripts. And unfortunately, there were a lot of mapping issues. We've had conversations back and forth with Allscripts to try to figure out the best way to be able to pull that data. And unfortunately, we've run into some barriers. So right now, a lot of that follow-up and pulling of the data is done manually on our end to get an idea of what our patients are dealing with and coordinate the efforts around enabling services to meet those needs. So recently we had a conversation about what would be the best way for us right now to pull that data. And unless we're utilizing diagnoses codes, we really cannot. And so the conversation with our providers and our staff has been around how do we better utilize those diagnoses codes so we can accommodate and address SDOH in an appropriate manner. And we know, I'm sure this is the case with a lot of health centers. We do know that the diagnosis codes specifically for SDOH are very underutilized. And so we continue to have those conversations and try to get our staff in the habit of utilizing them as much as possible. So in the next few slides, I've included, and I realize it's a little bit tiny, but I've included the questionnaire. So I just went ahead and copied and pasted in the questions so you can see what those questions look like. And I won't necessarily read all of them to you, but in terms of getting the demographics, in terms of asking questions regarding housing, questions regarding your education level, there's a variety of questions that cover a broad area of different social determinants of health. And then we're able to then follow up and address a lot of these. So if you go to the next slide, it should be the rest of the questions. And so we have 19 different questions. And this is the social part of the visit where our MAs go through these questions with the patients and then are able to mark off the answers accordingly. So if you look at the next slide, I briefly wanted to touch on Azara drives. So I know a lot of health centers are actually implementing Azara and are able to pull their data from their different EHR and take a look at, different aspects of their patient population, whether that's for this purpose, it's the SDOH data, but you can take a look at your clinical data, various quality measurements, any information that you really need. I know there's a FinOps module in there that we utilize a lot. We've incorporated a care management module. So we're trying to expand on the different uses of Azara to help us to not only just identify what the needs are within our patient population, but also to help us make informed decisions. Because sometimes, you may think you have a good idea of what the needs are within your patient population due to your understanding of parts of that population, but without seeing it on a population health level, it's not always informative for us to move forward and strategically plan to expand services that we currently have. So with that, I did want to specifically mention the social needs module, and this all comes with a disclaimer. I did pull these next two slides directly from our Azara module, but as I mentioned earlier, since Allscripts doesn't map to Azara properly, this data is going to be a bit skewed. But I did want to show you a glimpse of what it looks like in terms of what kind of information you're able to see when you do pull Azara and take a look at, specifically for this one, the social needs module, and then the next slide, looking at risk stratification. So I went ahead and pulled it for moderate with the understanding that this isn't very accurate. But on our end, like I said, we utilize the Allscripts reporting and a couple of other features to be able to take a better look at the SDOH of our patient population. So with that, I just wanted to go ahead and wrap up the conversation. So I think, health centers as a whole, when we make decisions about how to expand our services, how to identify what the major concerns are within the populations that we're serving, SDOH is such a big part of that. A lot of us are doing enabling services work, whether we have dedicated ES staff or not. And it's so important for us to be able to take those into account, because at the end of the day, how are we going to serve patients who don't have transportation and can't get to us? Or how do we serve patients who have other needs, such as food insecurity, such as, getting babysitting for their children so they can make it to an appointment? If we can't handle or provide them with support to address those needs, they're not going to walk in through our doors. And so understanding that, sometimes they get to the point where there's so many barriers stopping them from coming to a health center that they may not even seek medical care until, it's too late and they have to go to the ER. And these are things that we could have helped them in terms of preventive medicine that we pride ourselves in, but all these barriers are stopping us from being able to serve those communities. And so I think it's very important, data is such a big part of it, and knowing where to get our data and how to collect it is so important. And for me, it's a personal thing to know that the work that we're doing is so important and that we need to continue to make sure that we're able to pull the data that we need to be able to make these decisions. And then, like I said, expand those services. So at the end of the day, we utilize the Allscripts reporting, we utilize Azara. A lot of it is to also track a lot of the quality measurements that we need to make sure that we are providing quality care for our staff. And then, of course, making sure that every day we're serving these patients where we're able to understand what that looks like at a patient level, whether that's within just our patient population, within the community, and then looking at those demographics and different quality measures on a more holistic approach, and then making those decisions at an executive level, I think is very important. And so I know a lot of that conversation also comes with addressing a lot of the state policies, having those conversations on a national level, and pushing a lot of those policies and continuing to have those conversations about why SDOH is so important in the work that we do. So I'm going to leave it there and go ahead. My contact information is on the slide, and I will stick around to help answer any questions. Thank you.
Thank you so much, Nashia. We are getting a good amount of questions in the chat box, but also in the Q&A pod. So I'm going to invite you and some of our NTAP faculty to answer as many as we can in the next 13 minutes. And again, a reminder to everyone here today, we do have an optional office hours for another half hour after the top of the hour. So if you're able to stay with us, you can ask additional questions. So I'm going to start with an easy one, Nashia, with kind of the PRAPARE mapping to Azara and the EHR. Someone asked again, is this information pulling straight from your form into the EHR? So can you just clarify again how that data is pulled?
Sure. So the form is actually already embedded into our EHR. So it's their SDOH questionnaire. The issue is that it's not mapped to Azara appropriately. And this was actually a concern that we've continued to have voice to Allscripts. And I know MPCA, or the Michigan PCA, has continued to have conversations on our behalf as well to push and try to figure out how to make this work. Unfortunately, they need to be, I don't want to say it's a quick fix, but we do need Allscripts to be able to put that tool in for us to use. And until they move forward and do that, we can't really utilize it the way that other EHRs are able to. And so right now we're just struggling a little bit. We're able to, like I said, pull the data on our end directly from the EHR to inform a lot of our decisions and address the concerns of the patients. But unfortunately, it's not mapping to Azara like a lot of the rest of our data does. So Azara's information is not accurate.
Thanks, Nashia. And another question here is, one person talked about their patients who are food insecure, needing housing, childcare assistance for special needs children, etc. A lot of SDOH needs. Mm-hmm. Where does one start connecting patients to services? Is there a standard set of practices that you all adopt at MyCare? Sure.
So we have a couple of different people that are part of the care team that provides support to address SDOH. We have a community health worker who is able to do outreach to our patients, especially those with chronic conditions who need to be coming in on a more regular basis than just once a year. A lot of chronic care management. We have a nurse case manager, and then we have care coordinators. So the CHW and the nurse case manager do a lot of work prior to the visit, just to get us set up to understand what are their needs, what are they coming in for, what are the things that we need to address at each visit. The care coordinator does a lot of work before the visit in terms of pulling hospital records, taking a look at different things that need to be updated when they come in. And this usually happens a day or two before the visit. And so the information that we pull is fairly accurate. Once the patient does come into the office, the MA is able to then go through the different questions, including the social needs questions related to SDOH, and then identify any concerns. So, you know, if they're going through this I shouldn't say prepare, this SDOH questionnaire and identify that there's a need, say food insecurity or, you know, housing, then they're able to tick that off, but they directly send a message to our CHW or case manager or care coordinator, whoever that message needs to go to. And they're able to just send a patient message within the chart, and then the CHW is able to follow up. A lot of times, because we do have our CHWs on site, they're able to just walk them over and say, hey, you know, we need a little assistance in terms of identifying where they can get food from, or, you know, where they can go for housing. And our CHW is able to do a lot of that work just when they're here for their visit. We work with community partners to kind of address a lot of those needs. So, you know, we have the Gleaners food boxes that we receive on a monthly basis. We have community connections that are CHWs, our peer recovery coaches, nurse case managers. They have their own resources that they've built over the years. And we have our community partners as well. So we're able to close the loop for the most part internally, and then go ahead and refer them out or make a warm handoff a lot of times, and just connect them directly to someone who can assist. A lot of that's also helpful for our patients when we're dealing with behavioral health issues, because like I said, we are co-located. So we're able to just walk patients over if those services are already in the building and they just need to be walked over and connected to the next person who can assist. And so a lot of that is, you know, some of us would like to be able to have all these resources at the tips of our fingers, but we may not necessarily know these community partners. And so continuing to have those conversations with your staff and then building on those relationships that they already have is so important, because sometimes we think we know all the answers and that's not necessarily the case. We have a CHW here in Centerline who came from a different organization and has resources that he's connected to. And so, you know, I always encourage him, you already know what the resources are out there, so feel free to connect them with whatever you think they'll need to meet those needs.
Oh my gosh, there's so much rich insight and information you just shared there, Nacha. What I took away from that, and I hope the audience took away, is just the use of staff like the community health workers, promotoras, or anyone that is not necessarily a part of the clinical team, but can be part of the care team or team-based care model in your organization. We're seeing a lot of best practices around different states around the use of CHWs. And we're starting to see some great payment models, I think Missouri being one of those great states to really work with their state Medicaid offices to help sustain that work. And hopefully that'll start seeing spread across the country. So I'm gonna invite my colleagues. Oh, everyone's back. We have additional questions already in the chat box, but I'm gonna ask Colleen and Jamie from Corporation for Supportive Housing. How have you all seen organizations like health centers assist patients with housing insecurity? This person mentioned that alternative housing resources are very difficult to find for many case managers in their community. So yeah, how do you tackle some of these housing issues from the community health standpoint?
So I will say that housing feels like one of those areas that we're working on in a place of scarcity sometimes, but the best thing that you can do is just get knowledgeable around what are the housing resources in your community, because there are many different avenues in which they come through. So if you have people who are literally homeless, there is a continuum of care in a homeless system in your community that will have certain resources for homeless. If you have people who are veterans, there are certain housing resources that come through public housing authorities that are specifically for veterans. So the main area, the three main areas where there is the affordable and housing for those that are insecure are through your continuum of care, which is your homeless system, through your public housing authorities, which will have your public housing and all of the different vouchers, whether it is population specific or if it's just affordable housing vouchers. And most housing and community development offices, either through your local city or your county, has access to affordable housing resources or know where the affordable housing units are in your county or in your region. So those are the three main places that I would encourage you to start Googling, like in your region, right, to figure out what is there. But there is that kind of stress and strain around the scarcity of those resources. Though with some of the new money coming down, we might not be in the scarcity that we've been in the past, in the past decade or so. So it's an exciting time to understand where all that money is flowing into your community.
Thanks, Colleen. And go ahead, Yuriko.
And I was gonna I know there's some comments in the chat in terms of where to find resources, and there's some, we do see that there are some online referral platforms. And one thing that I do want to kind of shed light on is the fact that for some of our community-based organizations, they may not want to actually participate in these platforms, because when we think about our colleagues in that side of healthcare, if you will, there's really not an incentive for them or sustainable for them to actually adopt any of these online platforms. So just wanted to consider that in terms of, understanding that it's a great tool, but sometimes there may not be, it may not be feasible for some of our partners. And then I did hear from someone, it was actually from Trenton, New Jersey. They had done a pilot study in terms of using these online referral platforms. And one of the things that came up with was the fact that, a lot of our community-based organization staff, they want to feel comfortable knowing who they're referring to. So sometimes it's a matter of equity. Like if I'm a community health worker, I'm not going to refer out to someone that I don't know, that I don't have a personal relationship with. And when we think about discrimination and structural racism, sometimes if we don't know what the environment is like for some and some of our organizations, we may be doing more harm. So it's great to have online resources, and that's a great way to find that. But I think it's so important to have dedicated staff like Albert and Nasha have pointed out in terms of developing those relationships so you can vet them and kind of really understand if there's any gaps, if there's any learning points. Our communities are always changing. So if, let's say, we do have a refugee population that's increasing in our community, we need to do some vetting and make sure that we're able to refer out in a way that's comfortable and that doesn't do any more harm for some of our patients. Because the last thing we need is some of our patients to experience more discrimination in a way that will deter us from providing better care for our patients.
Thanks, Eureka. We're getting a lot of kudos and echoes on everything you've just said about the resources. And we're just acknowledging the time. Some of you may need to hop off to attend another meeting or eat lunch wherever you are in the country. So we just want to wrap up with some big key takeaways here. Hopefully, as a result of the presentation today, you understand the importance of tracking your enabling services and interventions that are most effective for addressing SDOH needs. Secondly, developing evidence-based practices to demonstrate to payers what it takes to care for patients with complex needs. Third is using evidence to inform your care transformation and payment models to really sustain the non-clinical work, as Nasha pointed out, around the enabling services staffing. And then lastly is just taking really small steps to lead to more sustainable progress. We like to talk about, working your way towards SDOH screening and then ES documentation. As Eureka's portion of the presentation outlined, you want the needs data in addition to the response or interventions data to really see the bigger picture for your patients, and documenting that electronically is going to help you all really make the case for payment and policy reform at the state and national levels. So with that, I'm just going to thank those who are leaving today. And if you are able to stay on board, please do. We have another 30 minutes just to really comb through some of the questions and share resources. And faculty, anything to add before people transition. Oh, yes, here's our contact information. You'll have it in the slides. Please ping us. Lots of knowledge here. And again, we have 3 more webinars in this breakthrough series coming up. So it's going to be every Thursday, same time, same place. So please register at the SDOH Academy website.
Thanks, Albert, and thank you, everyone. So I know we have 30 minutes of office hours, so feel free to raise your hand or add more questions in the chat box. I did see a couple more outstanding questions, so I could just read them off while we're waiting for them. So I think continuing with the screening tools, someone asked, does any screening tool check for mold in housing units during housing placement? Colleen or Eureka, would you be familiar with something like that?
That is a great question. I'm not familiar with any tools that have those questions.
And looking at the specific tools that I gathered for today's presentation, a lot of the questions focused on housing in general, but it was more of whether or not they had adequate housing. I think that's one of the benefits of being able to customize a SDOH screening tool. If you have a need or notice within your patient population that they are experiencing high issues with mold, I would incorporate that into your screening to figure out how best to address it and provide some sort of assistance for that particular need. But I didn't necessarily come across any in particular that asked for that type of question.
Yeah, thanks, Blas and Eureka. Oh, sorry, go ahead.
No, I was just going to say that not screening tools per se, but I mean, any kind of federally funded housing, affordable housing always has to either meet, you know, a set of housing quality standards, right? So they're ensuring things like lead and mold are not present before they would place a family or an individual into that housing.
Thank you. Yeah, I think that's great because I also remember someone in the Q&A also asking about child lead poisoning. So a lot of specific questions that we could hopefully assist folks with too.
As a previous CHW, I feel like a lot of times it was doing the home visits that you were able to get that information. Obviously now with COVID, it's going to be harder. I do worry just a little bit in terms of patients understanding how to look for it or understanding what it means to have mold in the house. But those are really great questions. So thank you for bringing that up.
Another question in the chat. Who do you recommend conduct the screening in a health clinic, RM versus social worker, et cetera, or is it best for PT to complete independently? Interesting.
I would say all the above. So we've seen from a lot of our PRAPARE users that we've recently had a Tiger team, which is really a group of PRAPARE users from across different, health centers as well as PCAs, HCCNs. And we actually asked this question in terms of who collects the data. And when we did this, there were none of the health centers or none of the participants said that providers do. So really, it could really be a community health worker. It could be a social worker. We found that there are health centers that are using patient portals or they're handing out the screening tool itself for the patients to complete. Obviously, when it comes to asking these questions, I would say the most important thing is to message it so that they understand what questions they're answering, because to them it might be no, and they might be going to their medical appointment like, well, why are you asking me about my housing, or my safety, so we have to still provide those connections for our patients. So I will love to invite other faculty members to answer or to add to that.
I want to add to that and just say it's really whatever works best for your current workflow. There's no wrong approach to it. So if it's a nurse doing the screening or the patient in the waiting room, it's whatever works best at your facility.
Thanks, Nalani and Eureka. That's really helpful. I also remember you guys had like a webinar discussing this specifically. I think I just asked Albert, but if there's any resource you guys could share about that, that would be helpful too.
I'll go and look and drop that in the.
Yeah,
I was about to do that, Eureka.
Oh, okay.
I just remembered you guys specifically discussing this topic, so I thought it'd be helpful.
Yeah.
And then another question. We have utilized Aunt Bertha, but being a rural area, we are still uploading local organizations and are not accessing them as of yet. Is there a way to get them utilized quicker?
I think that's going to be a really big challenge just based off of what I heard a couple weeks ago. You know, when we think about our community-based organizations, you know, they're contending with a lot of different reporting requirements, programs. And so being that there's different referral platforms out there, they might be approached by United, Unitas, 211's easy, like that's just an online, you know, way to look for information. But if they're being asked to document an Aunt Bertha, NowPow, and Unitas, it might be a matter of capacity. So I would say in addition to Aunt Bertha, you know, always go with 211 through the United Way. I would also say churches. You'd be surprised how well equipped churches are in terms of understanding the lay of the land. Local health departments are another great way to kind of get a sense of who's in your community. But in terms of adoption of these services, that's hard for us to answer. We're not at any of these, you know, referral agencies, if you will. But, you know, it's definitely a challenge we've heard before in the past. So it's a great tool. It's just capacity and really what's the incentive to have community-based organizations documenting this when, you know, it's really a matter of financial sustainability.
Thanks, Eureka. I love that answer of just leaning into community organizations. So
yeah, I mean, honestly, like community referrals and partners, you need to build community relationships. It's hard, like, and it takes time. And, you know, it's beneficial to have someone dedicated to that. Obviously, there's pros and cons because if that person leaves, those relationships leave. But there needs to be some level of investment in that connection with your organizations. And it's better. Patients can tell when you're able to refer very easily. Oh, yes, please see Sakura. You know, she's able to do X, Y, and Z. And having that level of feedback for your patients really makes it a warm handoff, even if it's virtual, but having that warm handoff, like, yes. I mean, think about social media and all the ways we learn about different companies or businesses. We learn about it by relationships. So it's the same way with community referrals and resources.
yes, thank you. And Emily put in the chat, we developed a toolkit for community partnerships that may be helpful. So please definitely check that out. And I actually had a connecting question to Nasha relating to like building these connections. So could you kind of describe how at MyCare you guys work to build trust with patients while asking potentially sensitive SDOH data?
Sure. So, I mean, I will refer back to the answer that was provided earlier in terms of trying to figure out the best fit in terms of who should be asking these SDOH questions. And I know a lot of times we go back and forth in terms of should it be, you know, the community health worker? Should it be the nurse? Should it be the provider? And so here with the care team, we've tried to do a lot of FaceTime with the patients in terms of, you know, the MA is always in the room. The MA is able to have these conversations when the provider is not available. And we also try to get our CHWs and our peer recovery coaches to come in and just drop by and just say hi to a patient, whether they're just walking into a room or on their way out, and try to incorporate them into the care of that patient. Sometimes they may not even know we have a CHW available unless the CHW is doing outreach or the nurse case manager. And so we're trying to get into the habit of conducting daily huddles I know in one of our sites, we actually do a daily huddle twice a day. So once in the morning and once for the afternoon schedule. And that way, when the MAs are there and we have our peer recovery coaches, we have our CHWs, we're trying to incorporate dental staff into that. We're able to say, hey, you know, this patient may be someone who may need assistance. If you want to just drop in for a minute or two and say hi. And so a lot of times that conversation needs to occur and they need to have a face and a name so they know that they can always reach out in the future. The need may not currently be there, but maybe a month down the road or 2 months down the road, they may remember, hey, there's a CHW at my care who can maybe assist me with some of these issues. And so we're trying to get in the habit of making sure that we're doing these introductions and we're going out of our way and spending a few more minutes with those patients and introducing them to the whole care team and not just the MA or the provider that they see on a regular basis. And so a lot of times, you know, we're putting in that effort and it may not come to fruition until a month or 2 months or, you know, 2 years down the line, but they'll always remember that those resources are available if they have someone who came and talked to them while they were there for their visit. And so we're trying to make all of that happen when the patient is here to meet with our providers.
Yes, I love how all these answers are just so tied together and how just being genuine and building relationships is really fundamental to every single aspect of care. So thank you so much for that. And then I think tied into that too, if you could kind of describe how data collection has been really useful or maybe challenging, especially with COVID, but just in general, what the utility but also the challenges have been for all these activities.
Sure. So one of the interesting things that we've noticed towards the beginning of the pandemic was that when we started to roll out telehealth, we know that a lot of people were hesitant. And then when they realized that they were able to spend, you know, have more FaceTime with the providers or the MAs, because all they have to do is just jump on, it's a video, you know, audio video call. And they're able to have more conversations. A lot of people started opening up, you know, especially in the beginning when, and now again, as we're going into our fourth surge here in Michigan and our numbers of cases are very high, people are willing to spend that additional time and have more meaningful conversations, I think. And that's what we've been hearing from our providers, from the care teams. And so people are willing to be more open, actually. So I don't want to say it's been easier, but in terms of segueing into the conversations about SDOH, like, hey, how are you doing? You know, we know there's a pandemic going on. We realize that a lot of people are, you know, working from home or unable to go to their jobs or have other issues that are spiking due to the pandemic. Let's have a conversation. Let's build that rapport. Let's talk about what your needs are. We've had patients where we've done telehealth appointments and they have food insecurity issues. And so, you know, I've had the CHW call over and say, hey, Nasha, can I just have someone coordinate dropping off some food boxes? Or can we coordinate how we can get them a ride somewhere? And so people are more willing to accept the help, I think. Even though those conversations are still difficult, we're doing what we can. And especially with many of the care team members making those calls, we're able to do what we can on our end, at least, to address some of these needs. We have a community engagement manager who, you know, once a week at least is making runs with food boxes and just dropping food boxes off at different patients' houses. You know, just leave it on the porch at this time, it'll be there, things like that. And so I think the conversations, I don't know about all of you, but on our end, they feel like they've become a lot more meaningful and people are a little more willing to ask for help. And so we're continuing to have those conversations and make sure that we're able to, I mean, obviously the data we're collecting is so we can actually meet and address these needs. So it's working out for us in terms of that aspect.
Yeah, it's really beautiful that people can feel comfortable and like trust everyone enough at my care to like really share that information. Yeah, I'm like surprised to hear that folks are more comfortable, but at the same time, I'm like, okay, well, that kind of makes sense the more you explain why. So that's really, really wonderful. And then I guess another question we have is, what is the biggest challenge and potential solutions when it comes to tracking enabling services at the health center, such as a closed loop referral?
So on our end, like I said, one of our biggest issues is that we can't necessarily extract that data accurately from Azara. A lot of times we are able to internally follow up on a lot of these needs between the different, I don't want to say service lines, but the different groups of people who are addressing. So say we have a patient who comes in, and a lot of times what we're trying to do is coordinate between dental and behavioral health, and then of course enabling services. So we're able to just do that warm handoff. A lot of times they're at the front, they're scheduling for their next visit. We're like, hey, do you need a dentist visit? We can go ahead and pass you off to the dental staff if you don't already have an established dental provider that you see. Or hey, with the behavioral health, they actually all go through a process of reaching out directly to the director of integrated health. So if someone comes in and we're like, hey, we do have these services available. If you're interested, we can just connect you. And the patient says yes. And then we just tell them, hey, expect a call from our office. And then we just direct that to the behavioral health team and they can follow up. So a lot of times we're able to close the loop because it's internal. If we're referring out for different needs, our CHW and additional behavioral health team members will make notes of it for themselves and then just follow up to make sure that loop has been closed. Our CHW here in Centerline is very cognizant of the fact, like for him, it's like his personal mission. If he states like, we need to address this and this and this, and then he'll give himself a timeline for, hey, let me come back around in a week and follow up, or let me come back in a month and ask these questions and make sure that loop was closed. And then being a part of that daily huddle is very helpful, because if there's certain things that he writes down and he's like, this needs to get addressed, he'll have that conversation with the staff, whether that's dental, whether that's behavioral, whether that's medical, and then say, hey, did we ever follow up and get this done? And so a lot of it is just our staff proactively trying to address these things. And then of course, making sure that we come back and ask, hey, did you do this? Did you do that? I'm not saying we're perfect. Of course, we run into a lot of issues where sometimes due to many reasons that loop doesn't get closed. And then we'll do our best to come back around and address it and do what we can. A lot of it, is patient education, having those conversations and helping them explain why they need to follow up with certain things. But we do our best, and the team is very supportive and able to do that, a lot of that internally, like I said.
That is really, really thorough. And I mean, it can't be 100% all the time, but that's like the best you can do. And I think that's really, really great. We have another question in the chat box from Kim. Do you have to get release of information forms completed to connect PT with resources, or are you connecting without specific identifiers?
Can someone elaborate on that, Kim? So, okay, so I see what you mean. A lot of times it's just a quick conversation where we're, I think PT is patient as well. So a lot of times when we're saying, hey, it's food insecurity, or we're identifying that, say it's a referral to a behavioral health service or something like that, we won't just release any information without having a conversation with the patient. We're not calling someone and saying, hey, this so-and-so patient needs help with this. What we're doing is bringing that patient in or having them on the line and doing that warm handoff where we're calling for them, or we're calling with them to connect them to those resources. And so I know the data sharing part of this whole SDOH conversation is something that we can probably take another few webinars and discuss. But I know on our end, it's really a lot of the CHW serving as a liaison and doing that handoff, because, one of the issues, of course, is that the data sharing is a big part of it. So we don't want to necessarily shoot off all this information regarding a patient unless we have a plan in place for how we're going to address it. And I think that in terms of the hub I think is what you're kind of referring to in terms of like the community hub of resources. We just do it directly and we just make sure the patient is a part of that conversation. I know it looks different in other states. I know I've done some research on that when I was at the PCA in terms of how we could best address it. I don't know that we're necessarily there yet, but I do know other states are, and I would actually love to hear more about this. So Kim, hang on to that question and maybe someone from NAC or AAPCHO can arrange for us to further dive into that conversation. Thank you.
Yes, Kim, feel free to provide your contact info if you'd like. Another question that we have regarding codes, what are the pros and cons of using the Z codes?
Who is that question for?
I think this was while you were presenting, I believe.
Got it. So the diagnosis codes. So I'll just be very frank. The issues that we run into on our end in the EHR utilizing those codes is that, you know, when we're seeing a patient and they're in our clinics and we're trying to identify all these different codes, one of the issues that we run into is that the provider is trying to address like the top 3 codes, right? So we have our medical codes, we have all these other codes that we need to add on to it. The issue that we run into is that you're limited on time, you're trying to address all of these issues, you're trying to get a good handle on what the patient is dealing with. And so providers tend to not necessarily focus too much energy on SDOH. I know on our end, we're trying to do a big push to try to figure out what is the best way to add on those codes, whether it makes sense for someone else to be reviewing and then having that conversation with the provider. And so I don't want to necessarily talk too much about this because I know we can do better. This is a process that we're kind of looking into right now. And so, yes, Emily just stated Z codes can also help demonstrate need to your payers. And so we're just trying to figure out what the best way is, honestly, for us moving forward, because I think the conversation comes back to, you know, eventually we would love for SDOH and the enabling services that we work to be reimbursable. And so it's really us leveraging that resource and putting us in a position to be able to do that moving forward. And right now it's a lot of work that we're setting into place so that we're able to prove to people like, hey, we are addressing this, this, and this. We do have these concerns within our patient populations that we're serving. And so, you know, as we move forward and we discuss policy changes or we discuss billable codes and have those conversations, we have the data available saying, hey, we've been tracking this for this many years or, you know, this many months. And this is what we're running up against when we're serving our patient population, and then moving forward and having those conversations about how we can possibly get reimbursed for the work that we're doing. So right now we're fairly new to the game in terms of identifying what's the best way for our staff to be coding for that. And I know, you know, my practice managers, our billing revenue cycle manager, continuing to have those conversations with the 2 departments to try to figure out a good common ground for us to be able to fully incorporate those conversations that are still happening on our end.
Thank you, thank you. I think related to how you answered the question just now, it's like another question that we had is like kind of more on an upstream level, like how do you want to use these codes and other services that you have to like really impact payment and policy landscape in Michigan?
Sure. So, I mean, this really goes back to a lot of the work that I was involved in at the Michigan PCA and continuing to have the conversations on a national level, specifically with a lot of folks even on this call, some of the colleagues on the call. I know it's so important for us to position ourselves in a way that we can show the data, right? We always have conversations like, hey, we know we're dealing with this, this, and this SDOH. We know we're serving populations that are vulnerable, but how do you show the data to move policy changes forward, right? And so on our end, even though we realize it's not billable right now, we need to put ourselves in a place where we can show that data when people are starting to have those conversations and people are willing to move forward and then determine how we can best pay for these services. And so right now it may not be billable or reimbursable or anything like that, but these Z codes are going to put us in a position where we can have data available, like I said, a few months from now, a year from now, several years from now, where we can say, hey, we're doing all this work and we're serving these communities, and this is why it needs to be billable, and we need to get paid for those services so we can continue to provide these services for the patients that we serve.
Thank you. And let us hope that these policymakers start making change really soon. And yeah, I'm sure they will with the wonderful data that we're collecting. Am I missing any other questions? I think these were all of them, team, unless I'm missing anything else. And feel free to continue typing in the Q&A box of the chat. But I do not see anything else. Give folks like a minute or so.
We've covered most of them, yeah, but we have 5 minutes left. So burning questions, please type them in.
I would say that with getting your teams at the health centers to do something new, it's going to take time. So just start small, right size it, see what works best. Like Nalani said earlier, you know, there's no right or wrong, just test it and just, you know, do it quickly and it's okay. You know, so start small, track your changes, track how it's going. Because obviously when it comes to change in your workflow, there's that emotional aspect. I hate to say it, but, you know, none of us likes change. So track it so that you're able to see what's the data aligned with the change. And then just right size it and you'll find the flow that works best for you. And all of us are here to, you know, if you have any questions, just feel free to reach out to us. But start small and you'll be surprised how quickly you can move in a good amount of time.
No more burning questions while we're still here. We have about 3 more minutes.
I did want to ask if anyone has any questions specifically for me that I can help answer, feel free to reach out to me. I'll go ahead and include my contact information in the chat.
Thank you, Nasha. Did I see a hand raised? No, it went away. Never mind. Oh, we have one question from Susan. Love the CMS Z code infographic. Weren't Z codes updated recently? And what is the best resource for an entire list of Z codes?
Well, Eureka, do you have that link ready, the crosswalk, at least from the crosswalk with PRAPARE? We have,
like 1 second.
Okay, thank you. We'll get that in the chat box for you, Susan. But yes, these things get updated a lot.
Yeah, we shared a lot of resources today, so be sure to check them all out. And Nasha put in her email, and definitely like lean into us too. Like we're literally here for you guys. So please feel free to contact and connect with us. And yeah, I just want to say thank you everyone again for showing up. And thank you so much, Nasha, for sharing your wisdom and knowledge.
Thank you all. This was fun.
Thank you, Albert. Yep, that's all of our emails.
So the data documentation crosswalk is actually, that's linked in the PowerPoint. So you should be able to find that when you get into the PowerPoint. Of course, I cannot find it right now.
Perfect. Well, at least it's in the PowerPoint, so we're fine.
Oh, you got it, Eureka. Perfect. There you go.
We're right on time. Yes, perfect. Thank you, folks. Take care.
Thank you all.